Carol, good, okay. All right. I think we can get started, AJ, if that's okay with you. We still are kind of a small group. People may trickle in, but we don't want to make the folks on the line wait any longer.
Yep, go ahead.
Sure. And I see AJ chatted everybody, but just a logistics reminder that if you have to leave the call for some reason, totally fine, but don't put the call on hold. Just hang up and dial back in when you're done with your other call, because we hear your hold music and can't do anything about it. Okay, so good morning, everyone. This is our last content-related session in this VLC. We meet again in 2 weeks for our final session, but in that session we sort of turn it all over to you guys. We hear from you about your group projects, and we've been talking to several of you in our individual sort of group project prep sessions. So just a reminder, if you haven't signed up for one of those, please do as soon as you can so that we can have a quick check-in with you and make sure, answer any questions you have and just sort of hear what you're thinking. Thanks to those of you who we've already talked to. You have good projects in place. We're excited to hear from you. In this session, we're going to go over homework from last time. We're going to do just sort of a recap on, a refresh on patient engagement and activation, sort of the spectrum. And then we're going to talk about some innovations in how different healthcare providers are using technology and other types of new sort of methods of engaging with their patients, new ideas in patient communication and activation. We'll talk a little bit about patient experience and satisfaction at the end, and then we'll see if you have any questions about your group project going into our final session. So homework from last time. What new technologies or care innovations have you implemented in your practice? So we have a lot of folks in this VLC who have implemented things related to population health. Bridget, which I believe is part of eClinical Work, their population health management software. We have the group that implemented Midas Care Management. We've heard from you. And then generally some people just we're working on embedding care plans within their EHR. And then one of our participants implemented a pretty robust assessment for a specific patient population for their geriatric patients, and then an associated health education class to sort of onboard them into their dental treatment. And it captures medical and social determinants of health and allows them to sort of triage patients and make sure that they are address urgent needs quickly, but get a full picture of their patient population. We asked about how sort of what results you were seeing from those new programs, new software. Most said that this was newly implemented and so hadn't seen significant results yet. Someone said they had been able to get some new statistical information for their UDS data, so able to use their UDS data in a different way, more meaningful to their practice. And then this last person found that the robust screening process and associated education improved sort of the efficiency of care and made their patients, it answered questions before their first visit so that they were more understanding of what would happen. They understood the process. They were able to more effectively communicate with their provider team, and that improved care coordination. And I thought this was interesting, improved their no-show rate too. So more engaged patients who understood what was happening. Maybe they understood the sort of the reason for their appointment better and were able to fulfill that appointment. So you may see benefits that you didn't expect from doing things like patient education or more expanded screenings. We asked about barriers, and they kind of fell, barriers that you've faced in implementing innovations or new ideas in your practice. They kind of fell in 3 different areas, which is very common. And I think none of those will be a surprise to you. They weren't a surprise to us. So the biggest one is always staffing and resource limitations. So not enough people, not enough money. provider buy-in, which is always important. So just making sure that what new ideas you're considering your providers are interested in and supportive and understand the benefit, the potential benefit, and it's always important to have provider engagement in any new project in your clinical setting, and that was reflected in the answers here. And then this organizational culture piece, which I love this quote, "We're still in the rut." So I think we can all identify with those challenges and doing anything new, no matter how innovative. And then this last question, how do we measure patient satisfaction and or experience, and how do you use the data that you're capturing? And so it fell into, people had a mix of working with a third-party vendor or developing your own process. And so we've seen, that's not surprising to us, that's what we see. And then some of you mentioned CAPS or HCAPS specifically, and I think if you're administering CAPS, you're probably using a third-party vendor, so that crosses a little bit, but we just wanted to call this out. So I think almost all of you are measuring patient satisfaction in some way, shape, or form, which is great. We don't always see that, so it's good. You guys are in a good place here. Any questions or comments about those homework questions? Any thoughts before we move into content for today?
On another note, this is Lauren Sala from Worcester County. We're having difficulties getting into the presentation. It just continues to say that it's connecting, and we have nothing. So.
Okay, thanks for speaking up, Lauren. AJ, are you able to follow up with Lauren to try and get her team into the...
try refreshing the screen and seeing if that works. If it doesn't, I'll try to help you with that after that. So just let me know.
Okay.
Thanks, AJ. And you can send, Lauren, if you can't get in, AJ, or maybe AJ, you could send her the presentation, and I can just kind of speak to what's on the slide. You can follow along if you're...
That's fine. Yeah, it's still just, normally it never takes this long. If you could just email that to Michael Trader, that'd be great.
Okay.
Great.
AJ, are you able to do that?
Yep, I'll do that right now.
Oh, Thank you.
Thanks.
Sorry.
Thank you. Thanks for speaking up now. Okay, so we wanted to do a quick recap of sort of patient engagement to activation, sort of the continuum of patient engagement. We've talked about this in previous sessions. Patient engagement is about sort of capturing those patients who have been attributed to your practice, make sure you know those patients are, outreaching to them so that they make it in to have contact with you as their care provider. And then there's different stages of patient activation. So you need to sort of build that initial relationship, build their familiarity with how your practice runs, who their care team is, what the sort of, in one of the questions from the homework, kind of that patient orientation and assessment process is that initial information gathering stage where you're learning about them and they're learning about you. And then the really hard work of patient activation comes in this shared care planning and following up on that care plan. And so that's really about, that's the long-term sort of getting patients connected and engaged in their care so that they're an active member in your care team. And I think Andy and Amanda talked about these in previous sessions, so we're just sort of rehashing some of the resources that were shared related to each of these stages of patient engagement and activation. So in that initial stage of sort of patient engagement and capturing outreach to patients and make sure they make it into you, some of those activities can look like outreach for preventative services, marketing campaigns, being active in your community, working more effectively with your payers, and there's some resources here that we've shared in prior sessions on what those types of activities look like and tools to get those moving if you're not doing that now. In this early stage of patient activation, building that initial relationship, asking patients, some activities that providers are doing in this area are, asking patients about their preferences as they build their treatment plan, basic communication if you've if you've done PCMH accreditation or something like that, communicating to patients who their care team is, information like that, that initial understanding of how your practice works. And then another activity, many of you, if you're FQHCs, you have patients on your board already, but another sort of way to start to engage patients and hear patient voices is a patient advisory council. So I'm curious if any of you we'd love to hear from you if you have a patient advisory council or if you have patients as part of your maybe quality improvement programs or something like that. And there's some resources up here for all types of providers, and then there's sometimes different approaches for primary care versus hospital providers. So there's resources up here. And then this long-term effort to get patients involved in their care planning and following up with them to reinforce that after you've done shared care planning. The activities here are sort of this long-term health coaching, intensive care management for complex patients, and actively involving patients in quality improvement efforts and identifying them as leaders in your practice through either representation on your board if you're an FQHC or that long-term relationship on a patient advisory council. There's some resources here. Does anyone have any experiences with, want to share about how if they have patients on an advisory council or patient representation on your board if you're an FQHC? Okay. I'm going to move into innovations in patient communication and activation. And so what we're going to do in this section is we're going to talk about some different kinds of health companies. So some of them are startups, others are working with safety net providers in other settings, but we don't, we just want to do a disclaimer that we don't have a relationship with any of these companies. And we don't necessarily endorse any particular company or approach, but they have some innovative models that we want to think about how some of the concepts that they're using and tools that these companies are using might fit or not in your practice. So Omada Health, is a virtual chronic disease management program, and they have a patented sort of evidence-based program called Prevent, and it helps providers or health plans, so they work with both. It helps stratify your patients and target certain patients who are at risk of developing chronic conditions like diabetes or heart disease. So they're targeting a specific patient population, and sometimes we see chronic disease programs that are meant to sort of target all diabetic patients or something like that. And Omada's approach is looking at people rather than focusing on that population. They're focused on the at-risk subset. And they target those, once they've identified those patients through their stratification algorithm, they target those patients with a specific enrollment campaign to engage them in the Prevent program. And then once they're in the event program, they get a variety of tools that are delivered virtually and supposed to sort of engage that patient, but in their home setting. And so they receive a home monitoring and fitness kit. They are paired with a personal health coach and a virtual support group. So there's some individual connection with that health coach, to one-to-one connection between a health coach and a patient. And then there's a peer support setting as well. And once patients are onboarded into that program, they have a 4-month course with weekly lessons. They get a daily check-in from that health coach, and then daily check-ins with their peer support group. And Omada, I think, began in a private practice setting, but they started with health plans and big employers. But they have worked in the last year with piloting a safety net specific program, a version of their Prevent program, and they've partnered with a couple of FQHCs in California. So they have, I think, 300 patients, last time we checked, enrolled in a clinical trial with 2 health centers in California, Petaluma Health Center, which is in Northern California, and Neighborhood Community Clinic, which is in Southern California. And they're evaluating the effectiveness of their Prevent program in a safety net setting. And I think they said that they made some changes to adjust for a safety net population. They definitely had to broaden the languages that their program was available in, and they're evaluating right now what other changes evaluating effectiveness and seeing what other changes might be needed. They have some clinically significant results, so they have found their model to be as clinically effective as in-person support, and then they've found some clinical results in demonstrated weight loss and improvements in A1C. So, just maybe what we wanted to do after sharing each of these companies is think about sort of the concept of the model that they're employing, and maybe we don't want to get too stuck on whether maybe Omada Health is the right partner for your clinic or not, but thinking about maybe some of the concepts and how they may fit or not with your practice. So just some questions for all of you. What do you think about targeting that at-risk population? If that would pay off for you, if you think that that's a valuable approach, if you wanted to do that, if you had the data to identify those patients, and if not, what would you need to have in place to do that? And then just some general questions. Do you have right now a standard, Omada's enrolling these targeted patients in a standardized curriculum, one that's the same with some personalized factors for patients, but it's a standard process for the patients that they enroll. And so we're wondering if you have some standard health education processes or curriculums that you want to share with the group. So maybe, Ariel, if you don't mind sharing a little bit, you may not be doing any of this, but you can just sort of share your thoughts about the approach. And if you do have a standardized health education program, we'd love to hear about it.
Hi, so I'm at the Gary Murray West Senior Dental Center, and we have an educational component that was created based on ADA materials. And so really the thought was that so many of the seniors that we're seeing haven't ever had the chance to learn about their oral health and how to properly maintain it. And also haven't seen a dentist in so long that we really wanted to provide them with the opportunity to ask questions and learn more. And also in the hopes that in the long run that'll create less cost for us over time, since most of our services aren't reimbursed. And so do you want me to talk about what exactly the class is, or kind of?
No, I mean, is it, and is this available to sort of all of your patients, or did you focus on a specific group amongst your overall patient population?
It's actually a requirement for all of our patients to go through the educational class first. So our target population are the seniors that come to the Senior Wellness Center where we're co-located, so seniors 60 and older, and 9 out of 10 fall below 100% of FPL. So they do a comprehensive geriatric assessment first, and then if they have any urgent needs or pain, then they're seen at the dental center right away. But we do ask those patients to go back through the educational component even after they're seen, because it allows us to have them in a group setting where they're seeing how dental health relates to their overall health, some of the treatments that they're going to be receiving, how it relates to some of their chronic conditions. And then at the end of the class, very few actually come to the dental clinic first. Most are going through this pathway. And then the registered dental hygienist completes this basic screening survey. And so we use like a stoplight report for that, where it's red, yellow, or green, and that helps us determine when they need to be scheduled. One of our goals this year is actually to implement a post-treatment class. So when they've completed their treatment plans at the dental center and they're going more to like a maintenance schedule, then we want to have an interim class between those 6 months, because we're finding that some of the seniors are scheduling unnecessary follow-up appointments because they want to have a connection with our staff, and many of their questions could be answered in more of a group setting. So that's kind of one of our goals, to expand that program this year.
That's great. Thank you for sharing. And you maybe, I don't know if that was your result that we shared earlier in the homework section, but you saw both your patients seem to enjoy this, and I think, did you see reduced no-show rates? So you saw results in other ways too?
Yeah, I mean, I think that was my comment, but I think the no-show, I think the strong driver behind the no-show is that our co-location, because they're already they're already coming to the center for meals and their other activities, and we're just right there. I think the education definitely helps because it prepares them for their appointment, so they know what they need to bring in terms of their insurance or income validation. We have a patient journey video that they watch where it has each staff member outlining what their procedures are going to be like at the dental clinic. I think when you're coming from a public health approach, a lot of times, free classes, sometimes it's hard to get people to go. But the feedback has just been overwhelmingly positive, and we have very high attendance at the classes. And one of the reasons for the post-treatment classes is because they've asked for more education and asked for more topics that are kind of specific for the senior population, like adaptive aids for brushing and things like that. So.
Okay. Thanks so much, Ariel. Any other comments, questions for Ariel? Or I'm going to keep calling on people, too. I'm sorry to do that, but you guys are good sports. So any comments or questions on the Amada Health model or questions for Ariel? Okay. So Health Leads is the next company we're profiling, and Health Leads is a program to help providers more effectively identify basically addressing social determinants of health and dealing with social determinants of health along with the medical needs of a patient population. And the way they do this is through a volunteer model. So they utilize volunteers to serve as these health leads, and the volunteers, there's a structured program to sort of train those volunteers and embed them in the practice. But the volunteers are the ones conducting the social needs assessment and then serving in this follow-up health coaching role. And I think this program began in, it began as kind of a pilot and a direct service model. So I think it was an F2HC in Boston that started to do this program, and they found it so effective that they have changed their company approach to sort of helping with a variety of services. So they can provide training if you want to build your own type of health leads program. They can give you their standardized curriculum to train volunteers, recruit volunteers, embed them in your care team. They can consult ongoing as you do that, or they can sort of come in, help you set it. They can set it up for you. They can come in, implement, and then step out once it's implemented. So they have changed their approach to really, instead of being focusing just on their own program within the provider setting, they are now, as a company, focused on helping providers implement this all over the country. And I think they began in a safety net setting, but now some of their big partners are more hospital-based systems. So they work with Kaiser in California, with Boston Medical, Johns Hopkins, and they have a pretty rigorous evaluation process too. So they have shown they feel that their model has proven effective in connecting social needs to better address chronic conditions. They've measured improvements in a variety of risk factors. They've definitely improved screening rates, and they have seen associated improvements in both provider and patient satisfaction. And so just some questions for you. I mean, I think this is interesting because screening for social determinants of health seems it's important and complex, and the idea of utilizing volunteers, sometimes that gives me a little pause. So when I started hearing about Health Leads as a model, I definitely just had some internal reservations about that, but I'm curious to see if maybe if you use volunteers if maybe you use AmeriCorps or something like that, if you've tried to use volunteers for that, what you think of that approach, if you have reservations too. Anyone have any thoughts on using volunteers to serve in a health coaching role?
Hi, this is Kayla from Cherry Health. I'm just wondering, do the volunteers have any particular requirements in their educational background or licenses, or is it just anybody?
I don't think there are requirements that it might differentiate. Could be different if you, like, different practices might have different requirements, but the model, it began with, college students, internships. So they had a standardized training, but not required certifications like a medical assistant background or something like that. So, so the original model did not have requirements like that. It just provided a standardized training, and clearly, I think part of the company's array of services is some key steps in how you implement the program. So they do have maybe some quality controls around what is important to have versus what you have flexibility around implementing. So they may have some standards there, but not required licenses or certifications.
Okay.
It's interesting. I mean, I'm glad that they're evaluating the model, but that's some of the questions I have is how much responsibility to give. It's a balance of what's required to provide high quality care to your patients versus volunteers they're not staff, and the more requirements you build into what you're going to have a job description, the more you'll have to pay that staff person. So it's an interesting model.
Yeah, at Cherry Health, we engage AmeriCorps for quite a few of our programs. And they would do things like screen for social determinants of health or provide other health education. And that can be quite successful, but I feel like we would do target recruitment for those positions. So we would hire people who have particular backgrounds in education or maybe somebody in public health or social work, something along those lines, so that they can start with more of a running start than up from the bottom. Yeah. But we do have also quite a few, not on the AmeriCorps team, but recovery coaches and peer support specialists. And they're not volunteers, but they don't necessarily have the educational background, but they do have the lived experience. So, it could work. I think you'd have to definitely have a very thorough screening process for the volunteers. It's different than some of the other type of volunteer work, like planting flowers on your property or something like that.
Yeah, that's a good point.
Interesting.
Hi.
Go ahead.
This is Ariel again. So we do our comprehensive geriatric assessment, and we have actually used student interns, I guess, better than volunteers, because they receive course credit for their internships. And so we partner with San Diego State University, and we've specifically looked for students in the health field. I know I'm actually looking for one right now that is a master's student in public health. And so at the beginning of the school year, we asked for a year-long commitment from them. And then they underwent training on doing a comprehensive geriatric assessment with our senior care navigator. And we did some inter-rater reliability type sessions to ensure that we were doing the assessment in the same kinds of ways and coding it with the same answers. It's been helpful for us just in terms of the volume to get, because we want everyone to have that first before they can come to the dental clinic. So that's helped us be able to see more people and kind of funnel them through the flow of our services.
Thank you to both of you for sharing. Do any of you have a standardized social determinant screening tool? Some folks we've worked with use the Prepare tool, so I'm wondering if you have your own, or if any of you have experience with using the Prepare tool to gather information like this.
At Cherry, we have a medical legal partnership, and we don't use the Prepare, but we use a tool called the iHelp, and and we use that just because we felt like it gave us a little bit more detailed information, and the Prepare was a little bit more general, so we wanted to we just prefer that tool. We'll probably end up using the Prepare eventually, because I feel like NAC is really big on the Prepare, so it'll end up in there someday, but so far we're just using the iHelp.
And does iHealth, is that captured in your medical record after, is that data captured in one place?
Yes. Yep. We have, when our attorney goes in, he does the iHelp tool to see where their legal needs lie. And then we are in process of building a report to pull all that data so we can say this many people were referred due to this type of problem and track them from there. We also tie it in with using the PHQ 2/9 screening tool and the GAD-7 for anxiety. So we can see, hopefully draw some conclusions about how health improves after referral to medical legal partnership. Also, we track A1C scores and no-show rates. So we're trying to prove that argument that getting legal help improves your overall health.
Yeah. And you're still in the process of that evaluation, yes? Have you seen results yet?
Yeah. We just started within the past 2 months,
That's
so
exciting.
we're not quite sure yet.
Yeah. Hey, good luck. Okay. So it's a good segue. I think we'll talk about a couple different programs that move into the behavioral health space. So Lantern is one. Lantern is a virtual behavioral health service that provides online cognitive behavioral therapy. And it's sort of I think it's started as a direct to consumer type program. But they are, they're open to partnering with providers or health plans as well, or I think even employers. But they provide a combination of behavioral health focused education and then individual health coaching from a licensed counselor. But it's all via computer or smartphone. And patients download the app. They complete a self-assessment within the app. And then the program and coaching, the resources and the individual coaching they receive is tailored to what they want and need based on that self-assessment. And so they will partner with large employers, provider groups, or health plans. And their results, they have demonstrated through their evaluation. So, they conduct their own evaluations, so take that with a grain of salt. But that online cognitive behavioral health therapy has been shown to be as effective as in person, but much less expensive and easier to access. And they, within their own user group, they have seen users report an average of 40% reduction in anxiety. So they're within the outcomes they're evaluating with their consumers. That's what they see. And so I know I think we have a couple of different behavioral health groups on in this VLC. So I'm curious how you feel about virtual support like this in the behavioral health setting, counseling via smartphone, things like that. So just generally your thoughts on that model. And then if any of you have used this type of support, and if you think it would be, sometimes we get pushback from safety net providers that it's not a good fit for the populations they're serving, which is totally valid. But I'm just wondering, as more and more people have access to smartphones and things like that, if that's shifting or if that's still not the right fit for the patients that you're serving. So any thoughts from folks on the phone?
I think this is Teodoro.
Hi.
Hello. Hi. I just think that pretty much it's already arrived. That there is teletherapy that's taking place right now, and the different companies that are using this technology in terms of carrying forth their not only the EMR function, but in terms of the whole counseling that they're doing. Now either through Skype, FaceTime, or even just by telephone. So I just think it's already here. I've participated in this, and I've found it to be quite helpful. I think it's also a way to really break down barriers, particularly people with comorbid chronic diseases. It just breaks down a lot of barriers in terms of not having to get a patient in who might be facing difficulty, having to come into for a regular office visit. So I find it to be quite useful myself.
That's great. Thanks. And so you're providing these type of services now?
No, we are not. We're a little bit behind. I'm just saying in terms of my other activities away from the center, I find the technology to be quite helpful. I think where I'm at right now within our Fairly Qualified Health Center, we're probably, I would say, a couple of years from that, but who knows what will happen.
Thank you. Anyone else? Okay. So Ginger.io is the next company. They're also within this behavioral health space. So they, Ginger.io combines virtual health services with home monitoring to provide behavioral health care and hopefully improve health outcomes. And so via a smartphone app, they, similar to Lantern, they connect patients with a variety of services, including 24/7 messaging, connection with a health coach, video counseling with a licensed therapist, video sessions, and medication support with a clinical psychologist, also online. And then what sort of distinct from Lantern is that Ginger.io, they monitor, sounds a little startling to me, but it's an interesting concept. So it monitors patients' smartphone usage patterns and alerts providers, it can alert providers when the algorithm recognizes a significant change. And then we'll talk more on the next slide, but this monitoring has alerted providers to when a patient is in crisis with enough time to effectively intervene. So they've worked with Kaiser Permanente in California, with UCSF in California, and then with Cincinnati Children's Hospital and Novant Health in North Carolina, among other provider partners. And with their pilot in California with Kaiser, they were focused on a specific patient population, but they claim to have used their algorithm effectively to intervene in some very critical situations. So I'm interested to hear what your thoughts are on combining home monitoring with the virtual behavioral health approach. Do you think your patients would be open to that? Do you think it would be helpful for them? Kayla or Kevin, any thoughts?
I think the home monitoring is throwing me off a little bit. I'd want to read a little bit more about it, maybe. Yeah,
so maybe not a total fit. No. Okay. Any other thoughts? Okay. So Maven is a company that focuses more in the women's health space. So it's a subscription-based telehealth company, and it has a network of a variety of kinds of women's health providers, like midwives, lactation consultants, primary care providers, and OBGYNs. And these providers are available. It's all virtual care too. So they're available through the Maven app. It's kind of an urgent care or quick questions type setting, but they can renew prescriptions and provide short video visits. And the way they market their services is as a complement, not a replacement to primary care. So they're kind of trying to fill the space between addressing health issues that you may have a health need that needs to be addressed urgently, but it's not at the level of needing an in-person visit, or maybe not at the level where the patient is interested in taking time out of their workday or to go to a medical visit. So they have some big venture capitalist funding. Those are some of their key partners, and they work nationally. So they have a national provider network. They're able to provide services in all 50 states, and they have some population-specific product lines, like a maternity product line, a college service targeting college students, and they've seen sort of retention with the users who are using them now. And what I'm wondering is, there's a lot of different telehealth services like this that are using this, trying to fit into this niche of a complement to primary care. And they're definitely a direct-to-consumer model. And so I'm just curious to hear from folks on the line if you think there's a fit for this in the safety net. I don't know if that's where a company like Maven is looking to grow, but I'm wondering how people on the phone feel about this type of video urgent care, if you see that as a viable model, as a complement to primary care, if that's something you feel comfortable with as a primary care provider, and then if you think that there's a fit within the safety net, or if there maybe isn't, if there's too many differences between like a college student population versus the types of patients that you're serving.
Hi, this is Kevin from Yavapai.
Hi, Kevin.
Hi. So I do think that there's definitely a place for these type of services within the safety net. One issue, though, and maybe others can give feedback on this, but my understanding is that most, if not all, major insurers, especially Medicare and Medicaid plans, won't reimburse for telehealth services or telehealth visits unless the patient actually comes into one of the clinics. So right now, what we're offering is telepsychiatry. So we have we have 3 clinics, and we have a psychiatric nurse practitioner at one of them, and then but patients in the other 2 towns can go into their local clinic and see her over through the computer. But that's our understanding, is that's the only way that we can get reimbursement for them. But we think that it would cut down on no-show rates and just make it more accessible to patients if they could do that from their home computer. So maybe somebody has something to share in regards to that.
This is Amanda from Starling, and I totally agree with you in terms of the accessibility on the patient side. I haven't seen any models that were specific to the to payers being willing to reimburse that. I think there's a couple of reasons why, but I would expect that as we get further down this trajectory, we'll see more innovation and more flexibility in the reimbursement. I can see plans being concerned about things like HIPAA and other patient protections, and as well as trying to kind of understand and monitor the visit on the clinical side from the primary care providers. But what we can do is we can do a little poking around to see if we have seen any models of that. Because certainly you can make materials and information available through patient portals, but those aren't billable interactions. So, but I think it's really interesting, and Sam and I can do a little more investigation on that and see what we can find.
Thank you.
Thanks, Kevin. Any other comments or thoughts? Okay. So the last company is Canary Health, and Canary Health is a virtual self-management support service, and it's actually based on, I don't know if any of you have utilized or had trainings from the Stanford Chronic Disease Self-Management Program, but that's a self-management training program that is targeted for safety net patients, and when we've worked with many providers who have sent their staff to have that training and have implemented it in their practice. So this is the sort of the virtual version of that program, and it's a patient-focused program that provides self-management resources and online customized health coaching, and then it also has a component that's supporting providers with patient outreach and reporting analytics. So it's focused on patient services, and then there's some provider support as well. And then they've recently added a caregiver-focused training enhance self-management support among non-licensed caregivers. So they have training for different types of roles within a care team. They have some big partners in the health tech space, Medtronic and VLC. They also work with Kaiser Permanente, and they're based. I think that the company partnered with Stanford Patient Research Center to sort of virtualize their program. I don't think it was something that grew out of Stanford, but that's a key partner of theirs. And the program has high levels of patient retention and engagement, good satisfaction ratings, and the payers and large providers that have evaluated their implementation have seen a financial sort of ROI as a result of reduced utilization in both unnecessary utilization of both outpatient and inpatient services. And they are in a variety of sort of clinical trials. They're evaluating their clinical effectiveness of the virtual program in a clinical trial setting. So I'm curious to hear from folks on the phone as how you provide self-management support to your patients now, and maybe we've talked this to death, but if you think that this type of support fits well in a virtual setting, I think we do. I think it sounds like the barriers are financial and payer related. But any thoughts about self-management support? Any trainings you've utilized to develop your care team?
This is Kevin again from Yavapai.
Mm-hmm.
So we're part of the county government, and we're actually, our FQHC is actually a separate department from our public health department, but they work together on a lot of things, and one of them is the chronic disease self-management program, which is a public health program, but we really try to refer clinical patients with chronic diseases into that program, and we have a hard time getting large numbers of them to attend those classes, but the ones that do attend, we tend to see, at least for, I would say, about a year after they go through the program, real improvements, especially among the diabetics. I mean, we tend to see like a 1 to 2% improvement in their hemoglobin A1C results. So I think that this is something interesting as to look into, if that could be, if that component, if people could attend virtually, like if transportation is an issue or something, where maybe we can talk with our public health department about would they be able to do that, like through Google Hangouts or something, where people that want to attend from home could attend. I've gone through the program, and I felt like the sharing amongst all the participants was really important. So I don't think that something that was video recorded would be as effective as like something that people can actively participate in, even from their home virtually.
Mm-hmm. Makes sense. Any other comments, questions? Okay. Any other, just before we move into patient experience and satisfaction, any other maybe like innovative technologies that you've been able to use in your practice, or any other patient engagement communication tools that you may have found useful? Okay. So patient experience patient satisfaction and experience. So we wanted to close this session about engagement with talking a little bit about patient experience and satisfaction, because it's sort of the end goal of this continuum is better health outcomes and happier patients. That's part of the triple aim. And so, why patient experience and satisfaction can get a little tricky. Sometimes there's, it's a hard thing to measure meaningful information here and know sort of as you're to gather the data in the correct way and then be able to use it in your quality improvement processes. So, why why is this valuable to measure? And so sometimes there's some common provider concerns that come up when you start to talk about linking evaluation of patient satisfaction or experience to maybe quality indicators, pay for performance type contracts. Sometimes there's some discomfort with moving into that space, and so some common concerns that that you might hear from your providers or that you might feel themselves, or how how can patients effectively rate the sort of the clinical quality of our care if they don't have medical training themselves. There's a discrepancy in the information that they're able to evaluate. And then what about this big one here, which comes up, I think, when you move into the self-management support space, but what about the things that we can't control? So what are the factors that are outside of our scope as a primary care provider? How sick a patient feels will impact the assessment of their care, and you don't have full control over that. So there's a concern about their evaluation being linked to things beyond just the service that you provided to them. And then this piece here, which I think probably comes up more in a behavioral health setting, is what if what's clinically indicated isn't necessarily what that patient wants. So, someone put us on hold. Hey, do you mind emailing the group? Oh wait, okay. One way for me. So this last piece, what if what a patient is asking for is not something that we feel is the best fit for their clinical need, and how well that's received and how that impacts their satisfaction. So those are all valid concerns, and they may not necessarily be linked to the evidence base, which shows that overall, basically improved patient satisfaction is positively correlated with their ability to follow treatment, with patients' ability to follow their treatment guidelines. If you're collecting patient satisfaction information through a good validated survey tool that collects, sort of guides patients to report experiences rather than how they maybe generally feel. Even a measure that can get controversial like satisfaction can be tied to quality in a meaningful way. And then, there's definitely links between increased patient engagement and health outcomes through utilization resources, through improved quality indicators. So the evidence shows a link between looking at patient satisfaction and patient experience, and having improved health outcomes in other ways. So there's definitely, there's two terms that get thrown out and that they can be conflated, and we feel like it's important to break out sort of the difference between patient experience versus patient satisfaction. In our view, patient experience is related to the overall engagement in care, sort of the culturally appropriate care, respectful interactions in a provider setting, and it's our thought that this focus on overall patient experience is probably more meaningful to you and to providers as a whole than looking at patient satisfaction. So I feel like that's where people are shifting to is overall evaluation of patient experience versus maybe satisfaction with one interaction and things like that. Some best practices in measuring patient experience and satisfaction: clear timelines and what you're evaluating. Evaluation of a specific encounter versus evaluation over a long, ambiguous period of time gives you better data. Surveys that focus on the provider, care team, and patient interactions. Timely measurement, and utilizing a standardized measurement tool to the best of your ability. So it's challenging here because there's a limited amount of industry-wide, widely accepted tools. CAPS and HCAPS are one of them. They don't have a perfect correlation in the safety net population. They're long, they're expensive, but some of you are using them now, and they are, if you're interested in benchmarking your results, I think using a validated tool like HCAPS or CAPS is probably the best way to go. That actually closes out our presentation. So this is our last lecture. We're a little early, so we have there's questions or comments about measuring patient experience satisfaction, we can take those now. And if not, we can let you get on with your day.
This is Kevin again from Yavapai. Just a question about what we can expect in 2 weeks for our last session. If you could touch on that, like what we need to bring to that meeting and all of that.
Sure.
Thank you.
So those of you who haven't scheduled your a check-in with the Starling team, please do that, and we'll talk more in that check-in with you about the final project. AJ, I can send you the sign-up link. You've sent it out a couple times, so we can follow up this session by sending that out. And all of you by now should have the final project directions, and a PowerPoint template. So there's an activity included in those directions where we ask you and your team to answer some questions related to a patient attribution workflow that you either might consider implementing, or maybe it's based on something you've actually done. So we ask you to sort of run through some questions in a table, summarize that in a PowerPoint template, and then send to me, Samantha, at this email here by the week prior to our final session. Let me check the due date for us before we get off the phone. So our final session is on the 18th, and we ask that you send me your slides by the 12th. And what I'll do is I'll put everything in one slide deck, and then what you should be prepared to do in our final session is spend 7 minutes or so, 7 to 10 minutes, talking to the group about your thoughts and your group project, why you chose the patient attribution workflow that you chose, and what questions came up as your group talked about it, and get questions from the group, feedback from the group. But it's not meant to take a ton of time, but just help you apply some of the principles that we've talked about and have the chance to talk with your peers as we close out the session.
Thank you.
Thank you, guys. Any other questions about the final project? Okay, so I'll stay on the line for another couple minutes in case anything comes up, and otherwise we'll talk to you again in 2 weeks.
Thank you.
Thank you, guys.
Thank you. Thank you.